Good evening, everybody. I'd like to welcome you all here to the seminar on primary healthcare, which was organized by the Primary Healthcare Group in SAHSSO, the Primary Healthcare Interest Group. The idea behind organizing the seminar was basically to get people together to discuss and debate issues around primary healthcare and to interact with the panel of experts we have here. So the seminar will be organized as follows. We will have 3 speakers do presentations. Firstly, Dr. Vugarelis, who sits seated in the middle, will present the state's policy on primary health care. Then Michael O'Brien, right at the end, will present the ANC Health Department's policy on primary health care. And then Reynolds, who's a member of the SAHSSO PPHC policy group, will present the SAHSSO PPHCN's perspective on primary health care. After that, we then call up David Saunders, who's the director of the public health program at UWC, and the speaker from somebody from the South African National Civic Organization who hasn't arrived yet, to come forward and be part of the panel. We will then allow the audience to interact with the panel. So, welcome, especially to the participants on the winter school. Some of you have come from very far and you've had a long day. We hope that you will find the discussion and the presentation is interesting. And also welcome to the speakers and thank you very much for coming. I'd like to call now on Dr. Vugarelis, who's the Regional Director of the Department of National Health and Population Development, to do his presentation.
Thank you, Gail. And thanks for asking me to speak to you as a group. Before I start off, I'd like to emphasize that I'm speaking on behalf of the state and not on behalf of any political party, because I find it most embarrassing when I sit on the panel and I'm supposed to speak on behalf of the state, and I find all parties, various parties represented, and I'm talking on behalf of I don't know which party, so I'm talking on behalf of the state. I think the concept of primary health care, I don't know in what detail I need to go in primary health care, but the concept of primary health care is not new. It has always been an integral part of the health services of South Africa. And I think in the early days of our health services, primary health care was the only form of service we had. The Alma Ata conference, which took place in the week of 6 to 12 September 1978, under the auspices of UNICEF and WHO, looked into at the health status of the world. And they emphasized that millions of people die annually from preventable diseases. 50% of the world's population do not have access to adequate health care. In one of its articles, the declaration went on to say that governments have a responsibility for the health of their people. Okay, can you hear me better now? Which can be fulfilled only by the provision of adequate health and social measures. They went on to say that the main target in the coming decades should be the attainment by all peoples of the world by the year 2000 of a level of health that will permit them to lead a socially and economically active and productive life. They saw that primary health care was the key of attaining this target as part of development and in the spirit of social justice. In 1983, in South Africa, we adopted these principles in the Health Services Facilities Plan. But this plan didn't say who was going to do what and how were we going to attain these various goals. On the 8th of May 1991, the Cabinet accepted the principle that primary health care is the key to attaining health for all as part of development, and that local authorities, as the government closest to the people, should render primary care services. I'm going to be vague and speak generically. If you ask me what is the state's strategy, I want to start off by saying that it is based on the following 6 ethical principle values and 5 principles. We look at the ethical values. We look at the dignity and the right of every individual to health care. Because if you define the basic right and accept that right, and define what basic care is, you set the moral limit of what government should provide or subsidize. We believe, secondly, that there should be a caring relationship, especially in this time of high tech. That concept must be accepted. Thirdly, that the least well-off and able to care for themselves should have access to such services. But it's not only this, the responsibility of the state, but also of the individual, and also a general social responsibility for the common good, and that we must rise above self-interest and focus on the common good. And here I'm talking of the health professionals, where we have to rise above our own interests, the community and the sectoral interests. We have to look at cost containment, especially because of the legitimate demands for resources in other areas, and I'm looking at things like education, housing, etc. And finally, on the basis of simplicity of organization. These 6 ethical values overlap the 5 basic principles of acceptability, accessibility, affordability, efficiency, and equity. And on the basis of this, the strategy of the state is built. Our biggest criticism that we've had was the fragmentation, and I'm not going to go into the 14 departments of health and the various empires that were being built around it. But what I have to say is that since April this year, officially the various own affairs departments and the Department of National Health have got together. Unofficially, since September 1990, the Department of National Health, House of Reps, House of Delegates in the Western Cape have been trying to function as a unit. The staff, however, are all on the same establishment at present, and we're trying to reorganize so that we can have a leaner and a meaner machine. Have you got problems hearing me at the back? Okay. If we look at what has been done already, the various school health teams, of the various houses are being integrated so that we can render one service for all race groups. But we aim that this service should be rendered by the local authority based on the principle that was accepted, that local authorities should be rendering the services. But there will be specialized teams responsible to supervise the service and for specialized aspects of the service. If we look at community psychiatric services, in the Western Cape, we've already embarked on the rationalization exercise, where in the past we had various teams visiting the same area, seeing the same group of patients, all of them saying that they are seeing all races. But utilizing the same clinic, the same local authority staff, that service has already been reorganized. There is very little duplication on the ground at present, and we're hoping within the early future to have cut out all unnecessary duplication on the ground. If we look at the running of day hospitals or community health centers, as I prefer to refer to them, in the peninsula, we've already started to run them as a unit, although the people are employed by 2 authorities at this stage, province and national health. We have 1 person responsible for all the day hospitals run by the Department of Health, which were prior to this reorganization run by the various own affair departments. Already we have extended services running 24-hour services in places like Elsie's River, Kailitsa and Richards Plain, and within the next 4 to 5 months, hopefully we will be opening 6 more of these services to bring the services closer to where the people are. We know about the closing down of Woodstock Hospital. 130 posts from the stock have already been moved down to the community. Health information is now being coordinated and integrated so that we can have one set of data which will give us accurate and timeless information on which to plan and timelessly address urgent needs. We already have a single administration with administrative staff from the various departments being integrated as one unit. The medicine code list has already been adapted. We don't have various code lists. And there isn't one for the House of Assembly and one for the House of Reps and one for the province. We use the same code list, the same source of supply. The pharmacists from the various regional offices have come together, and that includes province, so that a pharmacist will be responsible for one specific area. And we won't have one pharmacist going to an old age home and one from another house going to district surgeon and someone else going to the hospital. That has already taken place. When we look at primary healthcare in its totality, we've got to appreciate that it cannot be seen as something that is run in watertight compartments. The close association and interrelationship between health, social and economic development cannot and should not be ignored. Health leads to and is dependent on and leads to an improvement of the quality of life, but it is also dependent on the quality of life of the individual. So we see healthcare as an integral part of the process of socio-economic development. We've got to involve the community. The Alma Mater Declaration, as I said earlier on, said that people have a right and a duty to participate individually and collectively in the planning and implementation of healthcare. But this is easier said than done. Health workers have to be reorientated. They feel threatened. Our training in the past prepared them to make decisions on their own without consulting anyone other than their peers. And they ended up feeling that they could decide on behalf of the community. That whole component has to be retrained, and we've embarked on that already. Try and make people realize that they cannot make decisions on behalf of communities, that they have to participate with communities, that they've got to look at other workers in the health field, and that it's not their sole right. So that will take time, but we have embarked on that already. Secondly, politicians feel that they empower and control funds and the purse strings, which leads to wrong priorities, uneven distribution of resources. They see community involvement as a threat. So the state has a responsibility, and its officials have a responsibility to act as enablers and facilitators. They have to educate health staff, communities, politicians. They have to be impartial and impartially inform communities on the implications of decisions, of the cost of services that they're having. They have to enable a dialogue to develop between the community and the health family. And of course the state has a responsibility which it cannot run away from, of supplying the infrastructure and support systems to run the service. If we are to be successful, we have to involve the communities in their own service. With this in mind, we've started already on the situation analysis throughout the region. The only area where the communities are not yet fully involved, all the health professionals, is in the peninsula, for obvious reasons. But the Health Forum is an effort to address that shortfall. But we started throughout the region on the situation analysis, which involves health professionals and communities, where they actively look at the services, look at the cost of the services, the effectiveness of the services, the shortcomings in the services. They've identified duplication and needs. In this process, they are coming up with proposals, and it's interesting, they are redrawing the boundaries that we are used to. And These are aspects that we have to address. These proposals are looked at by a regional health coordinating committee, evaluated, and with recommendations to central government, where this is looked at again. This process has, however, led to communities and health providers coming closer together. The suspicion that we started off with 18 months ago is slowly but surely disappearing. New suspicions are coming up, new questions are being asked, but this is a healthy development. So if you ask me where are we going, as a state and state officials, we have the responsibility of being impartial, of facilitating and bringing about this dialogue. Seeing that there's equity, appropriate services, affordable services, and respecting the individuality of each community, because each community is different. We cannot sit in Cape Town and presume that we know what Springbok or Gail or George needs. Each one is different, and we have to respect that. So with that as a background, Lady Chair, thank you very much.
Thank you very much, Dr. Vugarelis. I just allow a few questions for clarity now, but if you can keep comments and broader questions for after all presentations have been completed. Are there any questions for clarity at this point? If there are no questions, it means everything was very clear, Dr. Vugarelis. Thank you very much. Next, I'd like to introduce Michael O'Brien, who's a member of the Western Cape ANC Health Department. Michael is also the National Chairperson of Health for Africa and the National Chairperson of the Confederation of Complementary Health Associations of South Africa. He's also a Chairperson of the Forum for Holistic Health and a National Committee member for the Mental Health Committee of the ANC Health Department. Welcome, and over to you.
Thank you, Gail, and thank you to SAHSSO for the invitation to be here this evening to share with you some of our thoughts on primary healthcare from the ANC perspective, and also, I think, to engage in something which is always extremely valuable. And it's even more valuable at this stage of where our country is at the moment, and that is dialogue between concerned members of not only the public, but people like you, who, in a sense, carry the responsibility of implementing further policies in the future. So in a real sense, it's not the people up here who are the important ones. I mean, we can make policy until the cows come home. But the important thing is what's going to be done with it. How is it going to be implemented? And this is particularly true of primary healthcare, which is the first level of interaction between the people, the communities, individuals and communities, and people who are providing services. And quite obviously, the ANC, because we believe that the power must be with the people, the first statement that we would like to make about primary healthcare is precisely that it must be the people who must be able to state their needs and make their demands known to the structures, to the professionals, to the healthcare professionals. It can no longer be a situation where healthcare professionals or government structures impose their will unilaterally and hierarchically on the people. To talk more specifically about the ANC position, at the moment, there is nothing cast in stone, and hopefully that will remain the case. We have statements, we have documents, and we have a position on primary healthcare. And it's embodied for everyone to see, for example, in the booklet Ready to Govern, which is readily available, that sets out our primary positions, and we are not going to change that very much. What we're busy doing is fleshing out policy. The other document that is available now is kind of final draft on the proposed structure of the National Health Service. So I will be quoting a little bit from these two documents to give you more specific points of our policy. I said just a minute ago that, in a sense, I hope that we never have a policy. And one of the values of where we are at the moment is anything becomes possible. We're still in a position where we can discuss, where we can work together and create a policy together. And that must be an ongoing process. And in a sense, it's the first aspect of primary healthcare which is necessary, that there must be a continuous dialogue between the people and the professionals and the structures. If we look at the ANC policy guidelines on health, the very first statement that it makes is that it's a question, what do people need to be healthy? And what we go on to say is something which everybody knows, that for people to be healthy, it's necessary that families earn enough money to be able to live decent lives and work under safe conditions. People need decent housing, adequate and safe water, sufficient nourishing food, adequate, decent toilet facilities, appropriate, effective waste disposal, getting rid of rubbish, industrial and human waste in ways that will not damage the environment, and life standards will be improved where people have a reasonable standard of education and opportunities for rest and recreation. And in a sense, once again, that's where primary healthcare is about. It's attaining, helping people to empower themselves and bringing pressure to bear on the structures to bring that into being. So those are the primary principles. I think that one of the major problems that we're going to have to battle against in the future is the current state of health services in South Africa. In spite of what Dr. Vugarelis has said, I think that the last 40 years of health provision in South Africa, although earmarked by many, many people who have given their lives to their fellow people as health professionals and with lots of goodwill, nevertheless, there has been this dreadful fragmentation of health services, which still tends to persist. There has been a total inequality of health services. And what's even more worrying at the moment, of course, is the fact that it would appear that the government is still fragmenting, privatizing, and in a sense talking the language of primary healthcare without actually implementing it in a really meaningful way. Now, if we go on just a little bit further about principles of ANC health policy, once again, obviously it's based on the World Health Organization documents which spell that out, and also obviously the aspirations of our people which are enshrined in the Freedom Charter. And the first description of primary health care is right at the beginning of our principles, and that is that primary health care approach is essentially one of community development. It aims to reduce inequalities in access to health services, promotes equitable distribution based on appropriate technology, and integrates the many sectors of modern life, such as education and housing. Further, It is based on full community participation. If the ANC is not able to do that in the future, then it will have failed. And I think in many ways, once again, in spite of what Dr. Vugarelis has said about the difficulties of community participation, I do believe that it's absolutely vital, and I do believe that it's possible. I think that you know that as well. But that means, once again, that it's the people on the ground, communities, who are going to have to be responsible for implementing primary healthcare policies. They have to take responsibility, and I'm sure that our communities, our people will be prepared to do that. Further on, the national health system will actively promote community participation in planning, provision, control, and monitoring of all services. The responsibility for healthcare will be coordinated between national, regional, and district authorities. Once again, with primary healthcare being at the core and at the leading edge of all those different levels. It's the foundation on which much of our health policy rests. Without the foundation, the rest of it comes tumbling down. And the first point of contact always will be with community health workers, primary healthcare workers, operating in the community, who are of the community and responsible to the community. The primary healthcare centres will once again have community participation and effectively control, with dialogue between community and the professionals who might be running it. Within the National Health Service, primary healthcare workers particularly, but all healthcare workers, must respect the rights of the individual, and people must be able to say how they need to have healthcare services made available. Those are just, that's a very brief summary of the ANC position. I would, before I finish, just like to say that I think that part of the problem that we are going to have to try and overcome together in the future is the fact that primary healthcare and the philosophy which lies behind it, which I've been trying to briefly describe, can only work if there is what is called a paradigm shift, which is happening throughout the world. In many cases, healthcare, as we know it at the moment, is based on the biomedical model, which is a relatively recent, primarily Western invention, if you like. And it's worked very well in many ways, but it has a lot of problem areas. And it's, I think, largely because of the biomedical model being accepted as the health model, that throughout the world we're having major problems. All governments throughout the world are having major problems with the whole issue of healthcare. And I'd like to point to two major changes which must occur in this shift in thinking. The first is that the biomedical model, by and large, is not a health model at all. It's an illness model, it's a disease model, it's a prevention of disease model. But it's not about health. So the most important thing that's going to have to occur, a shift in our own thinking which is going to have to occur, is what is health? What are healthy individuals? Who are they? And how do they remain healthy? And what are healthy communities? And how do they remain healthy? Much of the research I think that we must do in the future is about health, not about illness. Any of you who have been trained, like myself, as a clinical psychologist, I'm also trained within that biomedical model. And the core course that you do, the central course, is on abnormal behavior And I think this is crazy. I think this is one of the major problems that we have to change. We have to focus on health and the propagation and the teaching and education of people to take responsibility for their own health. The second problem is that basically the biomedical model is hierarchically structured. In other words, there are heads up there who know, and they tell the people lower down. There's doctors and there's nurses and there's physiotherapists. And underneath is the people who are patients. You know, they in a sense are powerless, they suffer, they've got the disease, and we will tell you what to do. It's also elitist. To get into medical school, for example, you have to have 6 A's, which keeps the elitist process going. It doesn't matter if you're a totally bad healer, if you've got 6 A's, you can get into medical school. And that's also true of clinical psychology. So that elitist element, I think, has got to go. We have to have people who are able to heal, who know about dialoguing with themselves about their own health, and who are able to help on an equal, interactive footing the people amongst whom they're working to achieve levels of health. Thank you.
Thank you very much, Michael, for that non-medical view of health. Next, I'd like to introduce Reynolds. Louis is a committee member of the National Progressive Primary Healthcare Network, of both the regional committees and the national committee, and he's also speaking on behalf of the SAHSSO-SA policy group.
I'll start off by saying there isn't really a clear progressive primary healthcare network or SAHSSO position on primary healthcare. As I go along, you'll understand why that is so. Because there are many very important questions that have to be asked about primary healthcare. Many assumptions that we're all making, and lots of easy, apparently very easy things that you can see clearly in front of us. But if you think more carefully, you'll see that we need to question the way we talk about things. And we have to undergo paradigm shifts, as Mike suggested. So all these crucial questions and issues have to be debated. And that debate is one that everybody really has to get involved in if you want to really understand what primary health care is about. It's clear from the discussion we've had that everybody wants primary health care. But we have to ask what it is. Vugarelis mentioned the Alma Mater Declaration, and that is really what most current thinking about primary health care is based on. The problem is that virtually anyone who reads it comes away with a different interpretation of what it actually means. And depending on your own agenda and your own background, you can sort of put any interpretation to it that you like. So, in one way, primary health care is first contact care. It's the first contact between people and health services. If you read Alma Mater in a different way, then you'll see that it's a comprehensive national strategy for health. You can also interpret it as a new philosophy of healthcare, the paradigm shift that Michael was talking about. Or it could be a movement for social justice and equity in health. Or, if you want to be more and more radical as you go along, you can interpret it as a transfer of power and control over resources and over health to the poor. Now, many people who talk about primary health care use some of these terms quite interchangeably, and you don't know exactly what meaning they're talking about now and what meaning they might be talking about later. And I think this is one of the questions, what is primary health care? The second, quite fundamental question is who is primary health care actually for? Is it for the poor only? Is it for the third world? Is it for the third world component of South Africa, as people are quite keen on saying? Is it for just the public sector, or is it for everybody? I think this is another important question that has to be addressed. And I think what we need to understand from these questions is that we in South Africa need to develop our own understanding of primary health care, what it is and who it's for. And this isn't just talking, this isn't just a question of talking. What has happened around the world since the Omaha Declaration is that there's been varying success. Although many governments have adopted it and they see clearly what primary health care is in their interpretation, the success rate is very variable around the world. And I think it's because of these different interpretations that people give to the concept of primary health care. Next one, please. Now, for the purposes of this discussion, we would like to distinguish between primary care and primary health care. Now, primary care, good primary care, is a good thing. It means that good, comprehensive, affordable, and efficient health services are available to people, and they're easily accessible to those people wherever they happen to be, whether they're at home or whether they're working. So that I would like to call primary care, and that's really what the health sector has to do. Primary health care is much wider. It includes primary care, but it's much wider than this. Basically, what it means is that all the levels of the health services, the primary care level, the tertiary care level, have to work together with the other sectors, housing, agriculture, education, and so on, and with the community in a process of healthy development. The other speakers have both spoken about the important links between primary health care and overall development. And this is also stated clearly in the state's health policy, where it says that primary health care is an integral part. I've written it down, you might not be able to read it today. It's an integral part of health services and general social and economic development. That's stated in state health policy, but I think you have to question underneath what it all means. So, having said that, primary health care is integral to development. That means that our understanding of primary health care is also influenced by how we understand development. And we have to ask what we mean by development, and therefore what we mean by underdevelopment. Now, there are two broad ways of understanding development and underdevelopment. In the one, underdevelopment is seen as a condition where some people, some countries, or some people, say within South Africa, have been left behind. They live in a state of backwardness, and they have to catch up to the developed people. And if that's how you understand underdevelopment and development, that means that primary health care, or that development, is a catching up process, whereby those that have been left behind will catch up and be the same as those that have gone ahead. The third world has to become like the first world. Like the third world component in South Africa has to become like the first world component in South Africa. Just ask yourself if that's possible at all. Can everybody live like the so-called first world people in South Africa? I mean, I don't think it's possible. So I think we can throw out that understanding of underdevelopment and development, and look at it more as underdevelopment as a process, which has been going on for a long time and it's still going on. And it's maintained by inequalities in power, access to power, and access to resources. And then the new buzzword in understanding development is the idea of sustainable development, which brings into development the issue of resources and the environment. And as an illustration of, this is a bit complicated, so I'll go through it slowly. As an illustration of the issue of underdevelopment as a process and the issue of sustainable development, I want to just introduce this kind of class analysis. Can everyone see this? Okay, I'll just go through it slowly. The world, people who use this analysis claim that the world has 5 billion people in it. There are 1 billion overconsumers of resources, of energy and so on. Okay, I think that's there are about 3 billion sustainers, and there are about 1 billion marginalized people, marginals. Now, I think we have a similar sort of situation in South Africa, but the numbers might be different. Now, how do you recognize an overconsumer? An overconsumer is a person who generally travels by car or by aeroplane. They live in a home where there's one family. And I think we need to look at ourselves as well here. They generally live in homes where there's one family living in the house. They eat packaged food. Lots of meat, most of their food comes in packets. Most of their drinks come in containers, like tins and bottles. How do you recognize a sustainer? Sustainers travel by bicycle or by public transport. They live in smaller homes often with an extended family, cousins and so on. They eat mainly grains and a little bit of meat. They drink clean water from taps, and they recycle a lot of their wastes. How do you recognize marginals? They travel by foot, they live in shacks or simple shelters. They go hungry, they drink dirty water, and I just want to come about how they use things. Right? The overconsumers use up about 60%, 60 to 70% of the world's resources, the energy, the produce from the land, and the produce from the factories. They waste huge amounts of stuff. They're responsible for 90% of the chemicals that are destroying the ozone layer and for the things that are causing global warming. Sustainers recycle most of these things. They're the people who drive second-hand cars if they do drive cars. They wear comfortable clothes, work clothes. Marginal people don't really waste anything. They only waste what they produce their own excreta. Now the middle group, the sustainers, are the targets of the multi-billion dollar advertising industry, trying to persuade them to become overconsumers. Now, who's primary healthcare? Which group here is primary healthcare for? Is it for the overconsumers? Is it for the marginals? Is it for the sustainers? If we're using the idea of catching up as development, can everyone in the world live like Americans, for example? I mean, these are some of the questions we have to look for. I mean, can everyone afford the type of healthcare that is called so-called first world healthcare? Sorry. Some associations. The overconsumers generally have stable populations. They don't have problem with population growth. They look with horror at the other groups, particularly the marginals, where there's a massive population growth. So every day there are more and more marginal people, and I think that's important. The whole world is shifting to the right on that analysis. Okay, let's have the next one. With this background, the two things that everyone agrees on is that you need to have equitable development, equitable health services, and they need to be sustainable. Now, equity and sustainability, if you look at them together, are quite tricky to put together in one sentence, if you like. Because, as I pointed out, I don't think everyone can live like the first world. So, what do you mean by equity? I think if we want to have equity and sustainability together, there's some very important things we need to do. I think we have to ensure maximal self-sufficiency as a nation and self-reliance. We have to democratize access to power and resources. We have to end the environmental degradation and waste and overconsumption, and we have to deal with the population growth problem. Even all that isn't enough, because there's other important issues that come into this equation are the issue which we're going to face soon in this country, the issue of foreign debt and structural adjustment programs. The World Bank and the International Monetary Fund are going to be throwing at us. And then there's a slight problem with democracy, because equity means that you have to, equity and sustainability together means you have to think about equity for the generations that are still to come, our children, our grandchildren. And voters vote for their self-interests today. What they want today is what they're going to vote for. So we need a culture that values the future, and we need to work on developing that kind of culture. And now, I want to get down to a few more concrete things. Everyone also says that there is any agreement amongst all the different people, disagreement, all the different people who talk about primary healthcare that you need community participation. As the quote at the top there again comes from the state policy that says that leadership from the community must be identified, recognized, and involved. Now, what do we mean by community participation? What do we mean by community? And I think the best definition of community participation that I've seen is that community participation happens when the community participates in activities that they have determined for themselves, not what other people have decided they must participate in, but they have decided themselves that they must participate in. And also there's a very important role here for civil society. Civil society is a kind of network of structures that any community sets up for itself. And I think it's through organized civil society that community participation becomes possible in primary health care. As Neville Alexander has pointed out, the network of grassroots democratic organizations in the townships and the trade unions, they're the ultimate guarantors of democracy, because they are the people who take the issues that are important to those people and mobilize around them. And I want to quote from a situation analysis that was done in the run-up to the PTHC SAHSSO policy conference that was held in December last year. Before that conference, teams of people went to different communities around the country to find out how they experience the health services. And these are some of the quotes. The people who use the health services experience many problems. They had to travel long distances, they had to stand in queues for hours, they were often turned away after having traveled those distances. Doctors and nurses looked down on them, often blamed them for being sick, and for other circumstances beyond their control, like they were dirty or they stank or something like that. And the health workers themselves, in lots of these places, were demoralized. They didn't treat each other with respect, and therefore they didn't treat the patients with respect. And this raises the issue of how health workers should show concern for people, their communities, and their families. The issue of concerned health worker practice, which is an important part of primary health care. concern with health worker practice occurs at many levels. It occurs at the individual level between a health worker and a patient. It occurs at the institutional level between the hospital or the clinic, whatever the establishment is. And it occurs at the national level where health policy makers must make a policy that reflects this type of concern. And then within the health sector, we expect health workers to show respect for each other. And this particularly concerns labour relations in the health sector. And now, the requirements, what do we need to make sure that primary health care can work in this country? And I think there's some underlying thing. We need a national development strategy, which includes primary health care as part of it. That national development strategy should involve all the sectors, education, agriculture, etc. It's not just a decision that the Minister of Health has to make. I think it's a part of national strategy. Secondly, it's some constitutional issues that have to be built in. The rights of civil society to organize themselves openly, and they should also take responsibilities. We need to get the balance between regional government and central government right in the new constitution, and we need to work out the regions and the districts. Without these things, it will be very difficult to implement primary health care. I just want to finish off by mentioning something about non-governmental organisations and the role they play. In South Africa, most non-governmental organisations in health are small and they work locally. They come from a background of opposition to apartheid and service in underserved areas. Now, over that time that they've been there, they've kind of evolved from providing services to providing training, to providing networking and linking up, say, academic institutions with community, different communities with each other, different projects with each other. And they've become agents of change and empowerment within communities. And they've built up an incredible amount of knowledge and experience in the democratic implementation of primary health care. And this is the kind of knowledge and experience that we need to build on. Now, to end off, I just want to mention some problems that we have with the current trends in the health services. Probably the most urgent one is the issue of unilateral restructuring of health services. Now, when we're talking from a primary healthcare perspective, I'm not that concerned with unilateral restructuring in terms of not consulting political organizations. I think we're more concerned here with unilateral structuring and not consulting communities. Because what's happening? What's happening now is that things are changing in the health services and no one understands exactly what's going on. So, for example, people are going to hospitals that are being turned away. They're going to day hospitals and they can't be seen because the project is finished. Sometimes, this actually means that sometimes people get angry with the workers in those places, and this amounts to a serious, urgent crisis, at least in the Western Cape. It might be broader. So that's one issue that we're not happy with. The second one is privatisation, which is carrying on. There's a new type of fragmentation in the health services. It's taking health services that should provide to the people in the country and privatising them. For example, doctors in hospitals are now being pushed to doing some private practice. People used to work entirely for the state before. The next problem that I have, at least with the way the state sees primary health care, is that the main policy direction is towards primary health care, yet it sees primary health care mainly as what I define in this talk as primary care. that first contact. And I think these are just some of the problems. Thank you.
Thank you very much, Ruby. You've said it all. Next, I'd like to call on David Sanders, who's the Director of the Public Health Program, to take his seat here and join the panel. I'd also like to inquire whether Caldula de Vries from SAHSSO has arrived. Yes. Would you also like to come up, please, Caldula? Before I allow you to interact with the audience, I wonder if Caldula wants to say something about SAHSSO, just as an introduction, because I'm sure you may be people who don't know what SAHSSO is all about.
Thank you for giving me this opportunity to popularize SAHSSO and put some things in perspective as far as SAHSSO is concerned. Firstly, the primary aim of SAHSSO was to put all the various civic organizations into one unitary organization. And because we've seen it in civics that each civic was operating very much in its own apartheid state, where CAF doing the so-called Coloureds, Western Cape Civics Association, we had hostel dwellers, and then CUSA. And there was a need for us all to see housing and the housing crisis in a holistic manner, so that the squatters' problem doesn't remain the squatters' problem. It becomes everybody's problem. And if we had continued in the way that we did operate, we would have been perpetuating apartheid in a sense. And therefore in April 1991, there was a launch of SAHSSO Western Cape. And in May, the launch of SAHSSO National, because we feel that it is a national issue. Housing has become a crisis. It is. And therefore, it's not only in one region that the problem is. It's a national problem, housing as it is. And SAHSSO has grown over the year. And we hope to unify all the different sectors. Presently, SAHSSO consists of hostel dwellers, Western Cape Civics Association, some of the affiliates that used to belong to CAF. Unfortunately, CUSA hasn't joined the fold as yet, but we are working towards it and hope that it would, in the near future, be a possibility, because it has created some kind of friction and conflict in certain areas. And ideally, it would be better if there is one structure so that all the different problems could be addressed at one forum. Thank you very much.
Thank you. I'll now allow time for comments, questions. Floor is open.
Thank you, Madam Chair.
Excuse me, could you just say who you are, perhaps where you come from?
Thank you, Nompulo Masinyana, Mrs. from Transkei.
Thank you.
Madam Chair, I've noted with pleasure the information from the first speaker about the attitude of the state, that of being a facilitator, and their concern to work on this. But one would like to be reassured that this would really be the case, that the state will not prescribe for people who will indeed be a facilitator. Which brings me to my second point, that of the second speaker about the biomedical model, which he says is illness-oriented. One would like to know how they are going to, what plans they have of converting this, in changing it from the wellness model to whatever will be suitable for the people in the future.
Okay, thank you. Would Michael like to respond to the question? I think the first was just a comment. Am I right? You have a loud voice if you want to.
If you can't hear, will you please indicate? I think that I've indicated that it isn't going to be an easy problem. And before I go on to try and answer it, it's not that I decry, I don't put down the biomedical model. I think it's very, very important. But in a sense, it's occupied the front place and perhaps the only place. To me, in a sense, to rely on it is to admit defeat. It's when a health system, a truly health-based system, breaks down, then you get illness, then you get disease. So it must be in place because it knows a lot about illness and disease and trauma. I mean, if you have a broken leg, or if you want a hip transplant, or if you need your heart replaced, in the physical sense anyway, then it's very good. So, but I see it as being a kind of secondary fallback process. The new model or paradigm which is evolving, I think is evolving throughout the world. It's not just in South Africa. And it's evolving in different ways. The implementation of it, practically, would mean, first of all, the understanding of a health-based system by, first of all, people who teach, who lecture in universities and technicons and at grassroots level. They, first of all, have to go through almost like a conversion, because if they don't teach it, then the same thing stays in. So training, I think, is very important. It's got to be people who understand what health is. Very often that starts with themselves. Lots of health workers still smoke excessively, take drugs. I mean, the worst, apparently the profession in the world which has the worst set of risks attached to it is dentistry. So I think the beginnings of that is to understand how to take care of yourself. And that's got to be a holistic process. It's got to be spiritual, emotional, and physical. And yourself as part of the context, the relationship, not only with yourself, but with other people and with your community. So the first change has got to occur there, I think. But secondly, it is going to mean that we're going to have to shift money and resources and personnel from being involved, I think, primarily still at the curative and preventative level, to many more people being involved at facilitating health and the education of people in what health is about. So how are we going to do that, I think, is difficult. But I think that once we actually grasp the nettle, so to speak, then ways can be found for doing it. I think once we're convinced that the only way to solve the problem is to move the resources there and move some more of the finances there, we will find ways to do it. But the primary thing, I think, is still that experience. For example, with AIDS, a lot of the research is still being done on how to hit the symptoms and cure it. What's very interesting is that more and more people with AIDS are now living, and living well. The quality of their life is very important. And there's it's finally dawning that what we should be doing is looking at people who can live with AIDS. And that will tell us perhaps a lot more about what AIDS is and how to deal with it. That's just one example.
Thank you.
Graham, we're second from UCT. Can I pick up for that question and put it to Dr. Vugarelis? The question of retraining, I think you called it reorientating the present medical staff, which I think is what has just been addressed. How are you planning to do that?
Thank you. I think you want that. Like Michael referred to it, firstly, we have to have a shift, a mindset shift. And that's not going to take place overnight. We had a school family planning staff originally. That group now is responsible for training primary health care staff. If we just take local authority staff involved in the Western Cape, we have over 1,000 nurses at local authority who in the past only did all family planning or mother and child or immunization. Now to retrain them into doing all the services. That takes some time. Secondly, for years we've said to people, and our training, as Michael has said, is train people according to a binary model. You now have to get them to realize that they've got to look at health. They've got to participate with communities. That health is not solely the function of health professionals, that there are other role players in the field. We have to train them to appreciate the fact that there's such a thing as a community health worker. We've started off to try and train community health workers and quickly realized that we cannot place community health workers on the ground before the professionals have learned to accept them and appreciate their importance. So the training staff that we had in the medical component are now being extended and addressing that need. One of your members, Dermot McLean, for instance, is all the time actively involved in sensitizing people on the need to change. Sensitizing the staff, making them aware of the need to change. I don't know if I've answered your question.
Not quite, but I do, yes.
Thank you very much, Dr. Vugarelis. I have another question from Elise, and then I'll take you.
Okay, it's, can I ask a question in one?
Yes, sure, Elise.
Okay.
Can you just say perhaps in your voice?
I'm not sure if these chairs, so I never know what side to give. The question is posed, the first one is posed both and the Vugarelis. Within the NGO sectors, we are quite worried about both of you have used, and just I'm saying use because that's what you've done. You've used CHWs in your talks as the first contact care for the communities. But we've heard many rumors that both the present government as well as the future government, which we know will be the ANC, is talking about not having community health workers in the new health system anymore. And we need to know exactly what is going on in that line. That's the first question to both of you. The second one, Dr. Vugarelis, I'm giving the time to think. The other concern that we have is this bill that we believe that we rushed through Parliament again. Another one that has been rushed through concerning the pharmacists and their role in primary health care.
Thank you, Elise. I don't know who's going to go first.
I'll take the first one, Elise, that I don't know where the concept that there's no place for community health workers. That is absolutely essential. We believe it's a need that come from the community, that are identified by the community. But I must emphasize that we cannot place community health workers on the ground before the professionals have been reorientated. where the professionals have been reorientated, that's what you start with first. Otherwise, it's a recipe for disaster, where we've tried to place community health workers and the health professionals have not been sensitized, if I can use the word. We spend more time trying to placate people, to stop unnecessary bickering. So you've got to reorientate. As far as the bill regarding the role of the pharmacist, I'm not fully au fait with what you are referring to. If you are referring to the use of pharmacists and the training of pharmacists in basic primary care, we believe that they are health professionals who have a role to play. I do not think that health is the prerogative of only doctors and nurses. They are health professionals, and we need to use their knowledge and their expertise.
Elise, perhaps in the far reaches of the Transvaal, let's talk like that, maybe down in town, but I haven't heard of any of those sorts of rumors at all. If I could just quote from the latest draft on the proposed structure of the National Health Service, which has just been submitted to the National Office, in Addendum 1, details of functions at District Health Authority level, comprehensive primary care. It says this addendum sets out the services that are provided in a comprehensive primary health care service. And the very first one, community level functions. These are the services that could be delivered by a lay or specifically trained health worker who lives and works in the community. One such worker might cover 500 to 1,000 families, could be either voluntary or paid, and it then lists the activities that kind of community. As far as I'm concerned, in my understanding of policy, there is no suggestion whatsoever. In fact, I would say the opposite is true, that the role of the community health worker will be seen as absolutely fine. I must say, though, that one of the things that worries me as a member of the ANC and also being involved in policy formulation is I think that there is some sort of split which comes out sometimes in our policy creation between people who come from a primary healthcare background and those who come from the more medically orientated background. And I think one of the problems there is that the people who are doing policy, who are creating policy at the moment, are doing it really late at night, on weekends, because they believe that it's very necessary. So it's absolutely no criticism. I'm part of that kind of professional, so-called echelon. But I think that there is a lack of sufficient input from primary health care direction in the formulation of policy. And I think we're continuously having to correct that process. I think that I would ask people who come from that kind of background and who would like to, at this very important stage of policy is being, take part in that. The ANC would welcome you with open arms. Throughout the country, people are desperately needed, and your expertise is desperately needed. So we would welcome you with open arms to become part of the regional health departments, to take part in the debate that's going on, to put your ideas. Because if you don't come forward in a sense, then it's up to people like some of the rest of us, as one of the exponents of it, a doctor who does understand what the primary health care approach is about and the importance of the total vital importance of community participation. But we do need people from the ground to make a greater contribution.
Thanks, Michael. I'm I'm not sure if Elise is satisfied with the response on the pharmacy, the role of the pharmacist. And I wonder if one of the other panelists want to respond to this.
I just wanted to make a comment about that question of Elise's on the role of the pharmacist in primary healthcare. I don't think anyone has any objections to more and more people delivering care. The issue is that what the pharmacists are going to do is that primary health care. That's the issue. And again, it brings us back to the beginning. What is primary health care? Is it just technological interventions, programs or services like that? Or is it a much wider sort of philosophy or an approach to health and development?
Thanks, Louis. I'll have you and then someone at the back, Bruce, and then our son.
Okay, Mokwana, Victoria. I've got two questions. The first one is the question of consultation. Whilst we realize that there is a gap in that communities have not been consulted, nobody has ever mentioned consultation of health professionals. Who are the people who are going to carry out this primary, the so-called primary health care? Because I think if they were, because these are people who are working, posts have been frozen, posts have been rationalized, people have been moved from one corner to another without any explanation and without any consultation how they feel about it. And I think that is why probably community health workers are not being accepted in certain places, because we are talking about sensitization. I think it should be more than sensitization. It should be consultation with the people who are the healthcare deliverers. The second one is also somehow related to the question of community participation. It is unfortunate that, and I want to challenge the member of the civics. It is unfortunate that the civics are supposed to be non-partisan, but most of them are aligned to certain political parties, with the result that people who are not aligned to those parties are found to be left out. So how can we make sure that everybody is being covered because of these non-partisan political party alliances?
So I'll start with the second question and then Dr. Vugarelis may respond to the consultation about it.
Okay, I will respond from a civic perspective. The civics is non-partisan. The fact is that anybody belonging to any political party has got the right to join the local civic. And it is at that level that participation can then take place. We cannot deny anybody his political persuasion. So if people of other political persuasions do not join a particular local civic, it cannot be held against any political party members that do belong to that civic. And we have called on different political parties in various structures already to participate on a health level. And so often, certain political parties do not attend these meetings in order to carry it over to their constituencies. But civics have never excluded anybody from becoming a civic member on the basis of a political persuasion. You're not happy with it?
I'm not happy with that because, I mean, in theory, that's what we are saying, but it's natural that because of the sort of slant to certain parties, people who feel don't belong will obviously not come. I mean, if you look at that AIDS meeting that we had last year, other parties were invited. I mean, like Uganda and all other parties. But they didn't come because they felt that this was a certain party thing. And that probably they are not welcome. I mean, as health workers, we find ourselves wedged between parties where people will say, please do not give help to that community because it's got a certain political slant. So and we are health workers, we are neutral. We give them services to everybody, irrespective of their political persuasion.
Okay, thank you very much, comrade. I think the point is taken there. Can we move on to Dr. Vugarelis?
question was consultation with the health professionals and not only with the communities. I can only agree with you. We're going through a long, drawn-out process now where we discuss this with various groupings of the staff. It shows you how democracy can be long-winded, but we have to do it. And things that in the past you were used to making a decision and letting it go down the line are now taking weeks and weeks to come to fruition because of that consultation. The risk you run, of course, is because you're consulting so long, you're accused of doing nothing. And then when you do something, you did it too quickly because you didn't consult enough. It's a catch-22 situation. But I can only support what you say. You have to consult across the full spectrum. It's not only the community. The health professionals are members of the community that you have to consult as well.
Yes, I'd actually like to just ask Dr. Vugarelis really two questions on that point. The first at the local level and the second one, excuse me, at a regional, at a national level. There's an example of a certain day hospital in the peninsula, which was going to be switched to a 24-hour service. I know that practically all of the staff there were demoralized, disillusioned, made very, very unhappy. Their private lives were upset, their professional lives were upset, because they were not consulted at all on this fairly dramatic change which was going to occur. That's one example, and it's repeated. I mean, it's an example of something which continues to go on. The second issue is consultation at a more global level. We know that there's been the National Health Forum set up, which is stammered and stuttered along. The government, as the Department of National Health, have initiated it. We have felt that because the ANC, and I think some of the progressive parties have felt that there are major problems to that. Finally, just recently, we agreed once again to have meetings. One of the first things that occurred there was the fact that we wanted unilateral restructuring to stop, and we wanted consultation on what plans were for the future, and particularly we wanted the issue of the academic health complex to be stopped at this stage, because we felt that the whole issue of privatization, what was going on in hospitals, and the problems which would occur in the future if the bill on academic health complexes was pushed through, would be enormous. And we were given a firm assurance from National Health that we would be consulted and that the bill wasn't going to go through. And I think it was about 10 days after that the bill went through. So I think, you know, that there was a question in one of the American elections recently about where's the beef in the hamburger? I think that's what we feel.
I think we feel the same sometimes. When it comes to consultation with professionals at Gail Hospital Community Health Centre, John, maybe you can help me out on this one, because I wasn't involved. I know that the original, when they started opening the 24-hour service, it was done with great haste, which we tried to overcome with the succeeding ones. We have learned, we did make mistakes, and I'm the first to acknowledge that we did make mistakes with that one. We were faced with a large amount of intransigence on the side of the staff as well, because of this paradigm shift that is taking place. And we are now rendering services much late into the night and through the night, and we had to face staff. we're hoping that with the success, the ones that are to follow, we won't have the same problem. I know that there's a meeting being organised at present with Gail's staff to address those very needs. So I agree with you. And we were wrong, and it's no good trying to deny that. Regarding national policy and the forum, I have not personally been involved, so it's difficult to react. But I know that last week there was a meeting again with the health forum to try, the health professional liaison forum, to try and get this thing back onto the rails again and talk about it. Regarding the bill of academic hospitals, I think we were as surprised as you are that it went through Parliament. We didn't expect this to go on. It was a process that was rolling. But I can assure you that our DG was as surprised as you are.
Okay, thank you very much. On the line, okay, you noted. Can we have Bruce?
I apologize to all the speakers for this being a little bit rambling. To some extent, I'm Bruce. I come from that far part of the Transvaal and I work late at night on policy. To some extent, my question is motivated by a little bit of a disappointment, not at the nature of what was said, because I think the fact that it was said as well as it was has brought about these questions, but a disappointment that we didn't direct our attention more directly to the issues of finance and governance, which each one of the speakers sort of flirted with for a while and then ran away from. Why I say that is because it's been my impression that at one level, the macro level, where the political debate is occurring, there seems to be maybe the generalization that one particular political party would like to see a unitary state with as little devolution of authority down the line as possible. And then there are obviously other parties that have variations on that theme or radically different, if you listen to the TV, radically different solutions. But none of the speakers actually grappled with the finance issue and the governance issue. Because the last speaker said that there are different interpretations of primary health care throughout the world, and that's probably why we've had varying degrees of success. I'd like to put this hypothesis. Is it not because there's a difference in emphasis between what the health sector understands as good governance and sound financial allocation, and what the government of the day understands by what good governance is and sound financial allocation. And it's the tension that exists there, and the tension that is unresolved, that makes it so difficult for us to have a primary healthcare system that actually works. And unless we sort out through the forum that has been hinted at here, unless we sort out that fundamental issue, we're not going to be able, either in the death throes of the present government or in the new life that the new government gives us, to be able to anticipate a really successful primary healthcare system. We need to grapple with those issues directly and immediately with some degree of expertise and urgency.
Thanks very much, Bruce. You've stated that hypothesis so well. I don't know who here wants to respond. I wonder if we can ask David Sanders if he wants to comment.
It's nice to be given the hard one. That's the first one. I'm not sure I understand it correctly. Let me rephrase it in the way that I understood it and see whether it's right, and then I'll attempt an answer. In the terms I understood it, I understand you to be saying if the government doesn't get its development strategy right, overall socio-economic development strategy right, then it doesn't really matter too much what's being said inside the health sector. So if the political, the economic, what you call the governance, the financial allocation and process are not correct, then primary health care will not be able to define itself in the brave way in which people have attempted to so do. Is that correct?
Yeah, just the practical examples. We heard the first, second, and third speaker say it's jolly good for us to have this consultation going all the way through and for the very clear roles to be visible throughout the system, this devolution of authority throughout the health system. And then there's this implicit understanding that they will therefore finance will follow that decision as well. The reality we know is radically different from that. We know that we don't have that sort of situation now, and I don't know whether we get it in the future. And I think that is the essential ingredient of being able to get a system off the ground.
I understand what you're saying. I'd actually like to take it a bit further. It does seem to me that if one looks at successful examples in developing countries, in South Africa, I noticed in the newspaper these days, is called a developing country, probably rightly so. The successful advances in health have been achieved in very few countries. There's a Rockefeller Foundation publication called Good Health at Low Cost, which gives 5 examples of countries which have achieved good health at low cost. Most of them are countries where the political dispensation is one of very substantial democratization, from experiments in social democracy in certain developing countries like Costa Rica or Sri Lanka, or Kerala states in India, which had a communist government for a long time, right through to countries like China where social revolutions took place. Those are the examples that are given. But really what determined the advances in health was the political process, fundamentally. What happened, how the political process informed the development strategy, and within that, the approach to health. And I think one really has to ask those hard questions. Louis talked about reversing the process of underdevelopment. The process of underdevelopment that's occurring in this country and many other developing countries, or underdeveloping countries, if one wants to be more precise, is situated within an economic, both national and international economic framework. The question is, how does one turn that around? Because if you don't turn it around, there aren't finances to be allocated to the health sector. Because as we see internationally, the international finance bodies such as the IMF and the World Bank are imposing structural adjustment programs, which means cutting funding to the health sector. But we're still, I think, suggesting an economic direction which is for quite a long time going to ensure that there are not funds available for general development. But that's the reality that we're in. So I think the very difficult question is, how does one ensure that this political process that people are talking about, democratization, does really empower those people who are disempowered to demand something different, something quite different, something that I'm afraid is not solely within the health sector. It really demands a completely different development strategy on the market. I think that's what we have to be talking about. We have to be talking about job creation, the situation of economic decline. We have to talk about how the health sector can facilitate that. The concrete example, since I may appear to be very abstract, is we've talked about this. The National Nutrition and Social Development Program, so-called food aid program, which is mostly about food handouts at the moment. Why isn't it the case that those monies and more, and we know that the drought relief program for white commercial farmers has been on the order of, I think, 3 billion rand, whereas 440 million are given to the food aid program. Why isn't some of that money mobilized to turn that program into a job creation program based on public works, for example, for which people will get paid to be able to buy the food that presently is given to them through certain agencies, such as Operation Hunger, which give food handouts.
It's that kind of thinking, I think, that we have to be talking.
Thank you very much. We have many people wanting to ask questions. One of our panelists also want to respond, but I think we can save that for later because there are quite a few people who have questions. Can we have our son next, please?
My name is Hassan. I'm from Cape Town and from SAHSSO. I basically just wanted to refer to Dr. Vugarelis' initiative. I introduced himself as the state and not the ruling party, but I'd like to put it to him that the state is responsible for carrying out the ideology of the ruling party. The state cannot be seen as neutral, and that is the image he tries to project in this particular people. And I'd like to challenge that. I don't think, if we look at what's happened to our health services over the last decades, we can see that its intervention has not been neutral. There's a more specific issue that I want to refer to, and that is the question of the introduction of limited private practice into our public hospitals. That was referred to by our third speaker. The state has committed itself to primary health care, but the introduction of limited private practice I see as a contradiction. It goes against the whole concept of comprehensive primary health care, and I'd like Dr. Vugarelis to respond to that.
Thanks, Hassan. Just ask people responses.
I'm trying to agree, Hassan. As officials, and I can only speak as an official, I have to remain impartial and as neutral as I can. Obviously, you do execute policies which come from above. There's no argument with that. But what I do say, however, is that as officials, we do not try and benefit one or other party. That's what I'm trying to put across. The question of limited private practice, that's another sign of democracy, and that came from consultation with certain professional groups.